have visited so many times Jaipur. We have always enjoy your speeches. You are the one of the wonderful speaker of the country, sir.
Thank you very much, Dr. Naval.
Yes, sir. Thank you, sir. Thank you.
So, hope my slides are visible to you now.
Yes, sir. It is visible, sir.
So thank you, Chairman, for the kind word. Thank you, organizer team RSSDI 2021. Thank you, outgoing President Dr. Bansi. Welcome to new President, veteran Professor Basant Kumar, and of course, young dynamic buddy, Dr. Agarwal. Thank you, BI, for giving me this opportunity. So this is a BI-sponsored talk. However, the entire slide set is made by mine. My duty is to give you a holistic approach on cardiovascular kidney outcome with SGLT2 inhibitor. So let's recapitulate some of the findings which has happened, in past 6 years or so. Remember, the first CV outcome trial of SGLT2 inhibitor came with IMPAREG CV outcome trial. Many of you might have been present while this data was presented at Stockholm at EASD in 2015. Now, since then, we have a number of outcome trial with SGLT2 inhibitor. Just should recapitulate this table, which is coming in the forthcoming textbook of RSSDI. I have wrote the chapter on SGLT2 and, incisive discussion on cardiovascular outcome trial. So many of you, if, when you get confused on which trial to remember, I would suggest you just look into this chart. This is a very simplistic understanding of how to read cardiovascular outcome trial. So far, we have got 3 sets of outcome trials done with SGLT2 inhibitor. You can see the group 1 is the trials which has been exclusively conducted in patients with type 2 diabetes, which includes, you can see 5 trials: IMPAREG, CANVAS for canagliflozin, DECLARE-TB for dapagliflozin, VERTI-CB for artugliflozin, and SCORED for sotagliflozin. This 5 trial was a US FDA mandated cardiovascular safety outcome trial, which was, a mandate in 2008 that all new anti-diabetic drug has to undergo a cardiovascular safety outcome trial. So these are the group 1 kind of trial. The second group of trials are done in patients who had exclusive heart failure. So you can see the group B, C, and D are the trials which has been conducted in patients with known heart failure. It could be a heart failure with reduced ejection fraction. It could be a heart failure with preserved ejection fraction, or it can be both heart failure preserved as well as reduced ejection fraction. As we saw in sotagliflozin trial, we had roughly 50% patients with reduced ejection fraction and 50% patients with preserved ejection fraction. For dapagliflozin, DEPA heart failure and IMPERA reduced were conducted in patients with heart failure with reduced ejection fraction. And IMPERA preserved, whose result has come very recently, and DELIVER trial with dapagliflozin is right now ongoing in patients with heart failure with preserved ejection fraction. So summarily, the group 2 trial are the trials conducted with SGLT2 in patients with heart failure. On your right hand side are the trials, which is group 3 trials. It has been done in patients with chronic kidney disease. The first trial which came up was the CREDENCE with canagliflozin that was done in patients with diabetic kidney disease, whereas DEPA-CKD was done in all types of chronic disease, including diabetic kidney disease. And IMPA-renal trials are still going on. So this is how you read into different cardiovascular outcome trial. Into group 1, these are the trial done in patients with diabetes, with or without heart failure, with or without CKD. The group 2 trials, patients with heart failure, with or without type 2 diabetes. And third group, trials with CKD, with or without diabetes. So these are 3 types of CV outcome trials which has been conducted in past 6 years. You know the results, so I will not go into detail. If you look into the result, one thing was pretty common in these trials, that in all these trials, the heart failure reduction was universal. You can see the primary objective was met with empiric outcome as well as canvas. It wasn't seen in the declared TIMI or in the VERTI-CV. The CV death reduction was exclusively seen with empiric outcome trial, 38% reduction. And the scored sotagliflozin trial was unique trial in the sense that these were the first CV outcome trials with SGLT2 where there was reduction in a stroke and MI. The earlier trial did not show any benefit in MI or a stroke. The sotagliflozin trial was one exception. As I was saying, the one unique finding was the heart failure reduction, which was a rule in almost all the CV outcome trials. The second thing, which was also pretty common, was the renal, composite endpoint reduction. That was also, more or less similar across all the CV outcome trial, although it wasn't statistically met in VERTI-CV and scored, but it went in the same direction. Now, remember that although the heart failure and kidney protection was seen in these CV outcome trial, these were not the primary endpoint of the study. And therefore, this would be only the hypothesis generating, and maximum you can conclude that these drugs have got potential to prevent heart failure as well as kidney disease. This will not suggest that you can use SGLT2 in patients with heart failure or kidney disease, but these trials do suggest that using SGLT2 inhibitor will have a potential to prevent heart failure and to prevent kidney disease. And therefore, you need an exclusive trial in patients with heart failure as well as CKD. And I will come into detail. We also learned that this heart failure prevention with SGLT2 is happening in every diabetic patient, irrespective of background heart disease, whether you are a primary cohort or you are a secondary prevention cohort, means with established cardiovascular disease or without established cardiovascular disease. The heart failure, prevention happened in every diabetic patient. Now, this was also replicated in large real-world studies. So many can say that these are the RCT. Where is the evidence in real-world scenario? We are the clinical practitioner. Do we see in clinical practice? Yes, we do. So this is the meta-analysis of all the real-world study we published, 2 years back, and just see the number of people in these real-world studies, more than 15 lakhs patients on a SGLT2 inhibitor. Still, you can see, and the primary outcome in these real-world studies were heart failure hospitalization, unlike the RCT, where it was exploratory endpoint. In the real-world study, with a primary objective of heart failure hospitalization, again, consistent reduction in hospitalization due to heart failure by almost, you can see 36% reduction in heart failure. This clearly suggests that SGLT2 are a wonderful drug in preventing heart failure hospitalization. Now let's look into, if that is the evidence, where is the evidence in patients with known heart failure? So let's look into the group 2 trials done in patients with heart failure. As you all know that we have got 3 trials data in patients with reduced ejection fraction. That was the DEPA heart failure was first in the list and followed by Impera reduced. Now we have data from soloist heart failure. If you see the primary objective of all these 3 studies, which was composite of CV death and heart failure reduction, you can see a consistent reduction. Therefore, now this data do suggest that if you have got a patient with heart failure, even if they don't have diabetes, you can prescribe a SGLT2 inhibitor to treat heart failure in patients with heart failure with reduced ejection fraction. And as I talked, in the soloist heart failure trial, 60% had reduced and 40% had preserved ejection fraction. So this was the first indirect evidence to suggest that SGLT2 might work even in patients with preserved ejection fraction. However, that needed exclusive, dedicated a heart failure preserved ejection fraction trial. Now, this data did suggest that you can see this meta-analysis which we published recently, when we combined all the trials conducted with SGLT2 inhibitor till date. Now you can find that in patients with heart failure, there is a significant reduction in the future chances of heart failure, even if you have got reduced preserved ejection fraction or a reduced ejection fraction, or even if you don't know the baseline echocardiography, especially in rural area, still the data suggests that despite you don't know the types of heart failure, the SGLT2 work everywhere. And these are the established patients with heart failure, with or without diabetes. Now, we also try to understand whether this benefit is happening in patients with diabetes or it is happening to every patient with heart failure. So this is a very recent paper we published, and we try to understand whether benefit of heart failure prevention or treatment of heart failure is subjected to people with diabetes. So we try to understand whether this benefit extends with varying degree of dysglycemia, and we could demonstrate that whether you have got a diabetes, whether you have got a pre-diabetes, or whether you have got no diabetes at all. If you have got a heart failure, then the future heart failure will be significantly reduced with SGLT2 inhibitor. So this is interesting finding that you don't need to have a diabetes or SGLT2 to work in patients with heart failure with reduced ejection fraction. So we also looked into whether this is only happening in patients with reduced ejection fraction, and we demonstrated, and this data was published prior to the Emperor Preserve trial, and we tried to understand whether benefit is happening to every patients with heart failure, whether they have got a preserved or reduced ejection fraction, and we could demonstrate that SGLT2 would be perhaps the first drug to show a prevention of heart failure in patients with preserved ejection fraction heart. Then the term came up from the Emperor Preserve trial, and for the first time in the history, we have got one anti-diabetic drug that has shown a significant reduction in the composite of CV death and heart failure in patients with preserved ejection fraction. This was the first trial with empagliflozin that shown a 21% reduction in patients with preserved ejection fraction failure. Remember the previous trial with a different drug like ERNI, with spironolactone or with ARBs or ACE inhibitor, they failed to demonstrate any benefit in preserved ejection fraction heart failure. The IMPA was the first trial in the form of Emperor Preserve showing a highly significant and pretty large reduction in the composite of death and heart failure. Now, if you look both the reduced and preserved ejection fraction side by side, this is an amazing paper from Deepak Bhatt and Subodh, and they could compare that SGLT2 works irrespective of the background types of heart failure, and you can see whether you are looking into Emperor reduced or Emperor preserved, the data is pretty similar across the board. Now, if you combine both Emperor reduced and preserved put together, there was an amazing this pooled analysis that suggested that from 25% ejection fraction and up till 65% ejection fraction, the empagliflozin shown a significant reduction in the composite of CV death or heart failure, thereby giving you a hint that irrespective of baseline echocardiography, if it is less than 65, the SGLT2 is going to work, irrespective of the type of heart failure. And no wonder this paper, which is published, 2 days back from the Deepak Bhatt and team, they for the first time came to the conclusion that SGLT2 would be the only drug which can be used in patients with heart failure with preserved ejection fraction, and irrespective of the background ejection fraction, whether it is a reduced, whether it is a midline or moderate reduced ejection fraction or a preserved ejection fraction, SGLT2 works in all variety of background heart failure. Now, the last part, if you look here, the data, how this heart failure benefit is happening, this is amazing to know that the benefit in patients with heart failure in these trials happened very fast. Look, the DEPA heart failure trial, the benefit happened at day 28. Once you have started the medicine at day 28, it was able to reduce statistically significant CB death and heart failure reduction. In Impera reduced, it was only 12 days. So empagliflozin started showing the magic at day 12, as early as day 12 in Impera reduced. And I was surprised with this recent paper for the Impera preserved. Even in the Impera preserved trial, empagliflozin shown benefit as early as day 18. So from 12 to 28 days of starting SGLT2, you are getting the benefit. Now, the question is how early you can use SGLT2 inhibitor in patients with heart failure. Now, this is the data that suggested that early you start the drug, the best benefit you are going to achieve. So this is the data with beta blocker, and this is the data with ERNI, and this is the data with MRA, mineralocorticoid receptor antagonist. Now look here, the benefit of starting this drug prior to the hospital discharge versus after the hospital discharge, there is a huge difference. This suggests that if you use the drug even prior to the hospital discharge, during the hospitalization, the drug is going to give you the best benefit. And this paper, which came a couple of days back, started suggesting that now start SGLT2 from in hospital. Once your patient is stabilized, go for SGLT2 even prior to discharge. And this is a fascinating evidence which is coming up for the future. And the one trial with empagliflozin is right now undergoing. It's called the Impulse trial, where empagliflozin is being used in patients who are admitted with acute decompensated heart failure. The similar trial is also going on with dapagliflozin. It's called DEPA-ACT heart failure trial, which is a RCT, and DICTATE heart failure trial, which is an open label trial with dapagliflozin. So this, 3 trial in patients with acute decompensated heart failure is right now ongoing. And empagliflozin trial is, is icing on the cake, that here the drug is started within 24 hours of hospital admission. And we are keenly awaiting the result from the Impulse trial. If the Impulse trial found or finds, positive CB outcome, then the SGLT2 will be the standard of care even in an acute hospital setting. But we have to wait for the result. Finally, I will take you into the renal benefit of SGLT2 inhibitor. In the previous CB outcome trial, the renal benefit was seen across the board in every diabetic patient. But these were just hypothesis generating without any dedicated renal outcome trial. Now we have got results from 2 dedicated CKD trial, Credence exclusively in diabetic CKD and DEPA in both diabetic and non-diabetic CKD. You can see a significant reduction in the composite of renal outcome, thereby suggesting that SGLT2 inhibitor work in patients with CKD, irrespective of presence or absence of diabetic kidney disease. No wonder that most latest KDIGO guideline, and this guideline, please remember, was based only on the Credence trial. When this KDIGO guideline came, the DEPA CKD result wasn't there. And even with the Credence trial data alone, the KDIGO guideline suggested that if you have got a patient with CKD, as you can see, with a eGFR of more than 30, and if your patient is not yet receiving SGLT2 inhibitor, and even if the HbA1c is well controlled, you stop the drug if the patient is not getting SGLT2 and put them on SGLT2 inhibitor. So for example, if you are using a combination of glimepiride and metformin in a patient with diabetic CKD, and even if his HbA1c is 7% or 6.5, you stop glimepiride and add SGLT2 inhibitor, That's a mandatory guideline in patients with CKD. This speaks volume about how SGLT2 protects. And I would like to show all audience here. This is a trial which is going on, and this trial is called a Renaissance trial. This is being done in a patients with a kidney transplant. Now people are believing that SGLT2 might prevent kidney damage in a patient who have undergone a kidney transplantation. This is one of the unique trials that gives a confidence that SGLT2 inhibitor can prevent even a transplanted diabetic kidney disease. This speaks volume how SGLT2 works to protect. Ladies and gentlemen, I'm not going into the detail. There are multiple mechanisms every day we come to know as to how SGLT2 protects heart and kidney through which mechanism. Nevertheless, the evidence is in front of us that it do protect heart and kidney ongoing damage in patients with diabetic heart disease or kidney disease. No wonder the most gentleman in the planet and the most beloved cardiologist in the world, Professor Braunwald, just wrote a commentary in European Heart Journal that SGLT2 inhibitor would be considered as the statins of 21st century. Remember, only 3 pharmacological agents has received Nobel Prize apart from insulin, was aspirin, penicillin, and statin. Now SGLT2 is going into the same direction, and Professor Braunwald suggested that this is the statin of 21st century. Thank you very much for your patience listening. Welcome to IDIAC 122 in Calcutta, which I will be hosting from 1st to 3rd July 2020. Thank you very much.